further delay, we will start. So the first talk what we're going to do is lenticular procedures in 2024. So now we all have been very well versed with LASIK, PRK, phakic IOLs like ICL, IPCLs, ICRIL, or all of them. But what is coming up in last 1 or 2 years is every company which you have dealt with an excimer laser is now coming up with a lenticular extraction procedure. So like how we transition from ECC to SICS to phacoemulsification, I think the refractive surgery future also is going to be from PRK to LASIK to femtolasic to lenticular based procedures, and of course IOL based procedures will have its own share when it comes to practice. So at this point of time, the different LALEX procedures which are available in ophthalmic practices are from Smile from the Visumax, Silk from the Elita platform, which is the Johnson & Johnson, the Schwind Atos, which is the Smart Sight, and the Zimmer provides with the Clear procedure. So these are the four different technologies which can help us with the lenticular based procedures. And all the procedures have different uniqueness when it comes to shape of the lenticule and energies. And what the new technologies are now focusing into is they are trying to go lower and lower when it comes to energies. So when it came to Zeiss Visumax, they started with 110 to 150 nanojoules. And then the Atos gives 75 to 135 nanojoules, and the Silk, which is from the Johnson & Johnson, goes to as low as 40 to 70 nanojoules. So different energies do have uniqueness and how the outcome happens. So that is what is different in each of the technologies. The going by machine to machine, the Visumax femtosecond laser, it was the first surgery which was performed, and it was introduced as the flapless, bladeless, painless, and a keyhole surgery, and it is known as SMILE. And it was told that the strength of the cornea preserved with the SMILE procedure is much better, or at least 10% higher than that of LASIK patients, because it involves a larger cut, which is the flap. The next came is the Elita femtosecond laser system, which is from the Johnson & Johnson. And of course, the patent of the lenticule and the side cut was there with the Zeiss Visumax Smile, so they couldn't take the same technology. So they went a step higher and they innovated a biconvex shape of a lenticule. And also they went lower energy, and the spot to spot separation was different, which gave a lesser tissue. There was no tissue bridges, so the dissection becomes smoother, which helps in a quicker visual recovery day one, having 20/20 or higher. Now in this technology, if you compare it with the IFS, they had an energy of 750 nanojoules and the spot to spot separation was 7 microns. However, in Silk, the energies have gone down to 40 to 60 nanojoules, and the distance between two spots is 1 micron or lesser. So because the distance between two spots is very minimal, the dissections becomes much easy, and that's why the day one outcomes are much more predictable. The Schwind Atos again has a different thing. It is associated with a companion diagnostic, which can be your MS39 Cirrus or Pyramis, which is a topographer or an aberrometer or an AOCT based topographer, and it helps to align, it helps to give a good accurate centering even when it comes to cases of high astigmatism. And it is compact and flexible and user friendly, and because of the different tissue geometry, the energies used here and the spot size and the track distance are separate. At this point of time, the Schwind Atos helps us to do two procedures, which is the lenticular extraction, which is known as the Smart Sight, and the flap creation for the femtolasic. And again, it has a lot of these parameters, but the most important ones which we have to know is it has a single piece PI. The offset for the treatment here is automated. The eye tracking is also automated. It has a static cyclotorsion compensation, because so it takes care of any cyclotortion during the procedure if it's there. And very different thing here is there's no lenticule side cut. So yes, the dissection does become little challenging when it comes to identifying the anterior and posterior plane, but there is no lenticule side cut, and the profile here is also semi biconvex shaped lenticule. Femto Z8 is from the Zimmer company, which is also the Clear, and it stands for corneal lenticular extraction for advanced refractive correction. And the difference here is you can have two planes, a separate one for anterior and posterior, or a venting incision for the gas to move out and help you with a smoother dissection. So what happens when it comes to shapes? So the different shapes, as I mentioned before, all these technologies have different shapes, and the smile has a plano on the anterior and convex on the posterior with a side cut, so it's a plano-convex shape. Silk is a biconvex shape. Both the planes are convex, so that means both the surfaces are refractive in nature along with a side cut. And AIOC is a semi-biconvex. If you can see, the anterior is somewhere between the plano and convex, and posterior is convex. So it's something between smile and silk, but here there is no side cut. So what happens when you have two different type of patients? How to make your outcomes very predictable? You have two sets of patients. The topographies are looking similar, refractive errors. You've done the same procedure, but day one patient has a 20/20 good quality of vision, then the other patient has 20/20 poor quality of vision. So in the past, what we have published is that if you have a stronger biomechanics, and I think this was done by Rushad when he was with us. So if you have a stronger biomechanics, the dissection is going to be tougher, and if the dissection is going to be tougher, the day one outcomes are going to be suboptimal. So that's why when you are starting your practice, you should choose a patient which is not a very thick cornea and moderate to high myopia, so that the dissection and everything becomes more predictable. Now, why does this happen is because whenever you have a stronger cornea or a thicker cornea, you are going to dissect it more tougher, and when you have a tougher dissection, you have something which is in your stroma. This is a confocal microscopy image. You have something like this in your stroma where you can see those white reflective bodies which are coalesced, and those are nothing but myofibroblasts. But if you have a smoother dissection, you don't see them. And this myofibroblasts are almost going to take 1 month for it to recover, and that's when you have a slower recovery in quality of vision. Your quantity of vision will be there day one, 20/20, but the quality of vision improves with time in cases of tougher dissection, and hence you should be very cautious in choosing a very thick cornea for a lenticle procedure in your beginning of the career, or a very small myopia. The second thing which is very, again, this was done by Rushad, who's here, so I'm just taking all his work. So second thing which led to poor quality of vision was something known as micro distortions. So if you have micro distortions, if you have a tougher dissection, or if your energies are not optimal, it's going to lead to micro distortions which is in the Bowman's membrane, and which is going to lead to poor quality of vision. So how do we prevent it? You just do a routine procedure like how you will do. This is the ablation, and then you find your planes, the anterior plane and the posterior plane. It's very easy to find the right plane. It's very important to find the right planes, because if you have a if you go pseudo entry into the posterior plane, then the dissection again is going to be tougher, and it's going to have a suboptimal vision on day one. So it's very important how you find the planes. And once you have identified the planes, you do a wiper movement to dissect the anterior plane first, and then the posterior plane, and then you remove the lenticule. But to prevent the micro distortions, what we are doing the ironing here. So just put some saline on the cornea, take the dissector and just iron the cornea, so that the whatever micro distortions because of Bowman's membrane are there are going to clear out, and that's when also will lead to good quality of vision day one. So to conclude, yes, when you are starting, it's very important to have personalized treatment when it comes to lenticular procedures, and choose the right case, and always do an ironing in your case, so day one outcomes are much better, and choose the procedure which is more comfortable for you. Thank you.
Any questions for Dr. Pooja? I think she has another commitment as well. So, Pooja, I'll put you on the spot. I think all the technologies are reasonably good, but which one do you prefer out of all these lenticule platforms?
So, if I'm a beginner at this point of time, as in no financial interest with any technologies, but if I'm a beginner at this point of time, I will probably go ahead with Elita. The reason is, I have done Smile, I've done AIOC, and I've done Silk, which is from Elita. The ease of docking, I know it's a two-piece PI, but the ease of docking, what I found with Elita is good. And once you have achieved your vacuum or your suction, it's very difficult to have a suction loss. Only if the patient moves his head, or it's squeezing a lot, then only you have a suction loss. Otherwise, in Elita, I have found very minimal chances of suction loss, which we have had with Smile and AIOC also. So that is one of the reasons I like, and whenever we are training our fellows, that's very important, because they want to learn the right way. And second thing why I like Elita is because of the dissection. The dissection is extremely smooth, because if you saw, the spot separation was 1 micron away, so dissection was extremely smooth, and that was one of the reasons it gave good outcomes on day one. And the third I like Elita is because of the biconvex shape lenticule, and because like, of course, there's a lot of data with this biconvex shape lenticule when there is a debate also, but in biconvex shape lenticule it preserves your spherical aberration, and because it's preserving your spherical aberration, the post-op quality of vision for all the ranges, distance, intermediate and near, even for an young patient or an adult patient, is quite well. So I think at this point of time, that's my answer. But again, it's, you have to choose your geographical location, what is comfortable to you, and that's how you go with the machine.
Because of the biconvexity, is there any difference in the lamellar separation between the
Yes,
smile?
so like if I do smile, I just have to go little anterior and dissect it out. But if it's a silk which is a biconvex, I have to like, when I am trying to find an anterior plane, it's like a football kick. I have to go up. And when I'm going to a posterior plane, I have to like dive in a swimming pool, I have to go down. So that is what we try to do, of course, but everybody has a different technique. So you have to have a different plane of separation, like a football kick and a diving in a swimming pool.
And I think another thing is regarding the energies in all of these, you have to kind of optimize. There will be a learning curve. Every machine will take you about 10, 15 eyes to optimize your energies to get your outcomes. So I would say don't get alarmed initially by one or two patients who are suboptimal visual recovery, because it takes a little time to optimize the energies.
Yes,
In all
initially you may
lenticular.
have a little bit of hyperopic shift or maybe a 20/40 on day one, but once you optimize it, maybe I would say 25 to 50 eyes. I think you are back to normal. And also the nomogram. So, thank you.
Thank you.
Thank you, Dr. Pooja.